Here I would like to discuss few key concepts about the hepatocellular carcinoma, which has been asked in the case study. Firstly, the mere presence of rise in AP level, alpha fetoprotein level, is not diagnostic for hepatocellular carcinoma because it's a serum tumor marker, and AP level could be elevated in many conditions. It could be elevated in non-neoplastic conditions of liver like chronic liver diseases, cirrhosis. It could be elevated, and it's also elevated in lot of other non-neoplastic conditions like neural tube defect. It could be elevated in pregnancy. It could be elevated in other liver tumors like hepatoblastoma, which is the most common cancer seen in the childhood. So just if you get a raised level of AP, it is not diagnostic or confirmatory for hepatocellular carcinoma. Similarly, there are a lot of cases where we don't get elevated level of alpha fetoprotein, though it's hepatocellular carcinoma, particularly when the size of the tumor is small, and secondly in the fibrolamellar variant of the hepatocellular carcinoma. Fibrolamellar variant of the hepatocellular carcinoma, usually less than 10% cases we get the elevated level of the alpha fetoprotein. And nowadays we don't use any serum marker for FLAC, but there are certain markers which has been found that their level is elevated, like neurotensin, vitamin B12 binding globulin. This new tumor markers tend to be elevated. Second concept that I need to discuss here, which is given in the case study also, that the pattern which we characteristically see in the hepatocellular carcinoma, that is trabecular pattern. Trabecular pattern means that if you look at a normal microarchitecture of the liver, in that you can see that at center of that architecture there is a central vein there. At one corner of that hexagon there is a portal triad there, which is made with bile duct, portal vein and hepatic artery, and there is a row of hepatocytes there. Usually the single row of hepatocytes are there which are connecting the central vein with the portal triad. So normally in the liver histology we usually see one plate thick, one cell layer thick hepatocytes. That is the normal arrangement. But in trabecular pattern, if you see the biopsy which has been given there, if you're seeing that there is a thick row of hepatocytes, like it is much more than one cell layer thick. It is in classical in hepatocellular carcinoma, it should be 5 to 6 cell layer thick, more than 3 cell layer thick characteristically, and that places I think it is 5-6 cell layer thick in that case, but it should be more than 3 cell layer thick. That is the characteristic feature. And obviously the normal microarchitecture of the liver, there is effaced in that condition, because you would not get the normal arrangement of the central vein, portal triad, and there's a row of hepatocytes which are connecting them. That would be absent in cases of tumorous or cancerous area in this condition. And in that case study, you are also given a clue, that is Mozambique. There are certain countries in the world, particularly subpart of the sub-Saharan Africa and in certain part of the Asia, where there was a lack of immunization for hepatitis B. There is a higher incidence of hepatocellular carcinoma. Mozambique is one country where there is very high incidence of hepatocellular carcinoma seen. That's why the case history Mozambique is provided there. And obviously the most common risk factor which is associated with hepatocellular carcinoma is cirrhosis, which is associated with various conditions which lead to cirrhosis, like chronic hepatitis B, chronic hepatitis C. It could be hereditary hemochromatosis. It could be Wilson disease in some cases, tyrosinemia. It could be aflatoxin B, which is a fungal mycotoxin, which can also act as a risk factor for the development of hepatocellular carcinoma. So if you look at that case study, you would see that they are providing that a person who is having a chronic hepatitis B, and he was living in one area where there's a high incidence of hepatocellular carcinoma, recently immigrated from there. He is present with the typical manifestation of hepatocellular carcinoma. He has his usual serum tumor marker AP level is very highly elevated. If it is very highly elevated, the AP level, then it is diagnostically supportive, a useful supportive finding. But not, at any cost, there is not, at any time, there is not confirmatory for ACC. And as you see there, that there is showing a gross specimen, and the gross specimen is showing a mass which is showing some bile tinge. Hepatocellular carcinoma, one interesting characteristic gross finding is this, that they show the presence of bile, because this is a interesting cancer where the cancer cells can synthesize bile. So if you are seeing a bile tinge over a tumor in the gross appearance, that is quite characteristic of hepatocellular carcinoma. And grossly, hepatocellular carcinoma can show three patterns. It could present with a unifocal mass, a large mass, solitary mass, or it could present with a multifocal masses, lot of lesions scattered all over the liver, or it could be diffusely infiltrative, that beneath the surface the liver cancer is spreading its tentacle all over the places. So these are the clues which have been provided there in that case study, and the findings are quite diagnostic for hepatocellular carcinoma. Particularly useful is the gross and the microscopic appearance. And the microscopic appearance there, they are showing the trabecular pattern which is characteristic for this. I hope you find this analysis of that case study useful. Thank you very much.